So good, so good, so good.
New spring arrivals are at Nordstrom Rack stores now. Get ready to save big with up to 60% off Rag & Bone, Marc Jacobs, Free People, and more.
How did I not know Rack has Adidas?
Because there's always something new.
Join the Nordy Club to unlock exclusive discounts, shop new arrivals first, and more. Plus, buy online and pick up at your favorite Rack store for free. Great brands, great prices. That's why you Rack.
Score more with the college-branded Venmo debit card and earn up to 5% cash back with Venmo Stash. Got paid back? With the Venmo debit card, you can instantly access your balance and spend on what you want, like game day snacks, gear, tickets, and more. The more you do, the more cash back you can earn. Plus, there's no monthly fee or minimum balance. Sign up now at Venmo.com/collegecard. The Venmo MasterCard is issued by the Bancorp Bank N.A. Select schools available. Venmo Stash terms and exclusions apply at venmo.me/stash terms. Max $100 cash back per month.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME will be in the show notes. This week, we are going to be presenting articles that changed our practice from the last year. We won't claim that these are the best articles or the top articles. They're just articles that we have found that we like that actually have changed what we do and how we talk to patients. We're going to present 4 articles, and then next episode coming out in a few weeks, we'll present the next 4 articles. So, John, you ready to get going?
Yeah, let's go.
All right. So before we start talking about articles, I just want to give a little bit of an introduction. As you guys who are listening know, addiction medicine is a constantly evolving field. And we as clinicians, or if you're a researcher, you have a professional obligation to keep up with medical knowledge. The American Medical Association Code of Ethics, which, has also been adopted by our professional society, the American Society of Addiction Medicine, it says that a physician must engage in continuous learning throughout their professional life. That's part of our sort of ethical principles. But how you stay up to date is kind of left up to the individual. The medical literature, which is published articles, is just kind of a little much. It's this ever ballooning collection of information. At this point, there are over 2 million medical articles indexed in Medline, which is our main database. In 2026, when I put this together, this was probably, at the middle of February, 172,621 articles have been added so far in 2026 in the first 6 weeks, and over 2,000 of them are associated with the word addiction. So there's no way a normal person could read even a fraction of these articles. And there's this bloat in medical publishing, just makes it a struggle to identify what you really need. As well as there being too much research, there's also research that you can't do a lot with. It might be about a medication that's not available. For instance, if there's great research about fentanyl and safe injection sites, but that's not really available in the U.S. Or the patients might be different from yours. We've read some interesting articles on smartphone addiction, but they're all done in college students, mostly white female college students in the Northeast, not really representative of our patients. Or finally, it's kind of cool, but it's like, can we do anything with it? This year there was some really interesting articles about fentanyl vaccines that keep drugs from crossing the blood-brain barrier. Really interesting, but not going to change my practice day to day because it's not available. So that's why we like to do this journal club. It's our service to you, our dear friends, and to find these articles that are needles in the research haystack that we hope you can actually do something with. And so with that introduction, we're going to start talking about some cases. And these are all cases that we've seen in our own offices. These aren't like fake teaching cases, and how the research changed how we do. So, all right, John, you ready for my first case?
Yeah, let's go.
All right. So this patient is a 43-year-old person, a veteran, a single father who has been stable on buprenorphine for opioid use disorder since 2018, but struggles with methamphetamine use as well. He uses methamphetamine when he has depressed mood, he needs energy, or he has to stay up all night researching and talking to AI, which is definitely not healthy. He's having worsening paranoia, delusions that have interfered with his ability to care for his daughter, to hold a job. And he says he'll try medications. He tries a few from me, including bupropion or mirtazapine, but he always stops them pretty quickly, feeling like they don't help. So what I used to say, there's no methamphetamine use disorder treatment program in the area where he lives. I don't really know even if it would help. I guess I'll just keep trying different medicines to reduce cravings. Maybe he'll stop using. So John, with a gentleman like this, what do you offer for treatment of methamphetamine use disorder?
I think it's similar. It's like a bunch of off-label treatments, right? I think we've got the Wellbutrin, topiramate, mirtazapine. Those are the ones that I typically kind of cycle through. Behavioral health intervention, counseling, IOP. Nothing that's kind of substantially evidence-based.
Right. No slam dunk. But then I read this article. The title is Contingency Management for Stimulant Use Disorder and Association with Mortality, a cohort study published in the American Journal of Psychiatry, 2025. So contingency management has been around since the 1980s, but like many behavioral initiatives, it can be hard to study on a large scale. So this large study of contingency management was finally made possible by the VA adopting standardized note templates for their contingency management group. So suddenly it was easy to collect data from multiple different contingency management groups in a standardized way and do a large database study on those contingency management patients. So the clinical question here, this was done in the VA, what is the association between contingency management and mortality and psychiatric hospitalizations among individuals with stimulant use disorder? And I just am going to say, in case anyone listening doesn't know what contingency management is, it's a therapeutic technique where you get prizes. Usually in the VA, it's like coupons that you can use at the VA store you can exchange them for items at the store. And the more negative urine drug screens or clinic visits or whatever is the goal that you meet, the more you get. So if you attend 6 clinic visits or have 6 negative urine drug screens, you might be able to draw a coupon from a fishbowl and win $50 or $100. So you accumulate prizes the more success you have. And if you have a slip up, you go back to the beginning and you start again at the small prizes and you have to build back up again. So it's an incentive, usually monetary, to do what you're supposed to do. And it works really well for methamphetamine use disorder. So that's what contingency management is. And so with the clinical question, they asked it using a retrospective cohort study done at the VA with a database that included 138,280 adults with stimulant use disorder. 1,481 received contingency management, and they were matched to similar individuals who did not, but who were similar in other ways. So really big study of methamphetamine use disorder and really big study of a therapeutic technique. We rarely see studies of therapies that have, close to 1,500 intervention patients in them. The outcome was mortality, very clean outcome, and the secondary outcome was psychiatric hospitalizations within a year of the index visit. So before I talk about the results of this amazing contingency management study, I do have to mention a few barriers. So, John, do we have contingency management at St. Max's Health System?
No.
No.
Well, you have a prized box, though, don't you? It's like it's like the poor man's contingency management.
I'm forced to run a self-funded contingency management program in my office by everybody who comes in for any reason whatsoever gets a prize. I don't know if it's working. Usually the threshold for contingency management to be functional is several $100s a year. So I think my prize box might not make it.
I thought it was $1 a day.
Yeah. So on average, we read another study. Yeah, it was $1 a day on average, $365 over the course of the year. You could win in prizes. And that seems to be about an amount that is effective. But if you give people more money, it's more effective. But there's a lot of barriers, as there are for many addiction treatments. The first, I'm just going to list a few. So if there's more than $600 in prizes, it has to be reported to the IRS as taxable income. So both the patient and then the therapy group or the institution has to report the income to the IRS. There's a lot of stigma, viewing it as sort of bribing or paying people to be clean. Like, why? Who's going to pay them to be clean? Why don't they just do what they're supposed to do? There's no funding to purchase the incentives. Like, who do you bill? Like, do you bill Medicaid? Like, you can't really bill Medicaid for this. So who pays for the incentives? Then there's anti-kickback laws because actually it's illegal to pay patients to come in for billed federal medical services. And a lot of people perceive that there's a limit of $75 for the incentives to avoid any of those anti-kickback laws. There's also sort of limited grant funding. Sometimes the contingency management program is limited to people with only stimulant use disorder, despite it being useful with other use disorders. And then you have to train staff to support and maintain the contingency management protocols. They have to do it right for it to work. So a lot of barriers to implementing this treatment. So let's talk about the results. Remember, we're looking at mortality and its association with contingency management. So 4.8 deaths in the contingency management group and 8.2 deaths in the control group per 100,000 person days. Overdose deaths, 10 in the contingency management group and 15 in the control cohort, again, per 100,000 person days. So after they adjusted for all their covariates, the reduction in mortality risk associated with contingency management is 41%, which is awesome. There's also higher rates of hospitalization in the contingency managed group, 45.9% compared to 36.4% in the control group. But that's not necessarily a bad thing. Patients in the contingency management cohort utilized healthcare more, and they were more in contact with clinicians and perhaps more likely to be brought to care, to go into the hospital because they were sick. So bottom line, case 4 again, my 43-year-old veteran and single father who's struggling with methamphetamine use disorder. Medications aren't really helping. Instead of just sort of trying more medicines and hoping for the best, I'd say let's get you to a VA-based stimulant use disorder program. And there's several VAs in our area, or at least sort of close. And I could say I think it would be worth doing. It could save your life, and let's get you to that program.
Really cool.
Yeah, it was a great study because, these studies of therapies are hard to do because of the heterogeneity of the technique. And so this study is just a little bit unique in terms of size, and I'm really glad they did it. So thank you guys for doing that paper.
Yeah, I think it's like increasingly recognized as your treatment of choice for this, right? I think we're past the phase of does this work? I think the question is how do you do this and fund this? And I think I've given you my annoyance about some of this. A lot of this is through grants, and the problem with grants is that's not really as sustainable. We need to have this built into budgets.
Well, it's not sustainable, and it's sometimes not flexible. Like the grant might be just for treating one population or in one area. But what if someone outside the area wants to be treated?
Yeah.
All right. Should we hear about your next case?
All right. So this is a second case of a patient I recently saw in my office. So it's a 35-year-old male with a history of untreated hypothalamic growth hormone deficiency, depression, opioid use disorder, and stimulant use disorder. They present to clinic for the 4th consecutive week. The patient reports feeling that their opioid use is out of control. They're currently using 2 to 5 bags of fentanyl daily. 4 weeks ago, the patient attempted their buprenorphine dose, which was 8 milligrams, but experienced sweating, nausea, and autonomic instability, leading them to fear precipitated withdrawal with further doses. They continue to attend clinic visits, but refuse inpatient stabilization and have not taken any buprenorphine since the initial dose. The patient expresses interest in the depot buprenorphine formulation, but is hesitant to undergo the recommended 1-week oral lead-in. So what I used to think here is that I'm sorry you're going through this, but there's not much else I can do in the office for you right now. My medical recommendation would be either referral to a methadone maintenance program for induction at any point in disease course, inpatient stabilization for symptom control with a monitored buprenorphine induction, or possibly a very low dose initiation schedule. But given your history of what sounds like precipitated withdrawal, I'm concerned about starting the depot buprenorphine without an oral lead-in as kind of previously recommended. What do you do in these cases, Sonya?
Well, it's so interesting. I had sort of forgotten, but I was thinking about it as you read that case. I had a similar patient. She must have had 6 or 7 visits just to talk about starting buprenorphine, and she had the buprenorphine at her house, but she never quite started it. She kept making appointments, and we kept talking about how it was going to go, and she kept not feeling right, and never being able to kind of start the buprenorphine. And I didn't really have much to offer. I'm like, well, whenever you're ready, we'll just go for it,
Yeah, I think these initiations are challenging, right? I think there's so many different ways to do it. I know like the low dose initiation schedules kind of gotten a lot of favor to it. I just find that very complex for patients to follow my written instructions. I feel like half the time I'm describing it to a colleague and I can see like deer in the headlights as I'm going through this protocol. So I think it's a big lift. So something that's easy, quick, that we can do in the office, is what we're always looking for. So I read this article, Rapid versus Standard Induction to Injectable Extended Release Buprenorphine. It's a randomized clinical trial from JAMA Network Open. It's for 2025. The clinical question is rapid induction of injectable extended release buprenorphine safe and effective as standard induction among adults with opioid use disorder who inject opioids or use fentanyl? And this was a multi-center open label RCT from October of 2021 to January of 2024. It went across 28 different outpatient treatment sites in the U.S. and Canada. Participants were adults, so age 18 or above, with DSM-5 moderate to severe opioid use disorder and active high-risk opioid use, or screened. And out of 1,434, they enrolled 729. They randomized people 2-to-1 to this rapid induction group, and they also substratified patients by fentanyl-positive urine drug screen status. So they were trying to get that higher risk induction subgroup stratified between the two arms. The intervention was the rapid induction, which is you do a single 4 milligram sublingual buprenorphine, followed by a 300 milligram extended release injection at the initial visit. You follow it up a week later with another 300 milligrams. So you do your load over that 7 or 8 day period. The standard induction was 7-day oral lead-in of sublingual buprenorphine, and then you did the 300 milligram induction dose or initiation dose a week or more later. Do you have a favor of the two of those? I mean, as the standard induction is kind of the one that was initially kind of released with the marketing product.
I almost always do that standard induction with 7-day lead-in because the timing works out well in my office. People come in, they get a visit, we do an assessment. I give them a prescription for sublingual. I got to order the injectable. It can be anywhere from 1 day to 5 days, depending on what day of the week the patient is there. So making a 1-week follow-up works out smoothly. That's what I have to do.
Yeah. Yeah, I think it's more of you're right, exactly, a workflow issue than kind of like a clinical practice out of necessity.
Yeah, exactly.
The outcomes here were, the primary outcomes was treatment retention at the second extended release buprenorphine injection, so that's week 2. Secondary outcomes were retention and injection 3, time to treatment discontinuation. They really were interested in this as retention by fentanyl status. Safety events, they looked at withdrawal symptoms, adverse events, labs, EKGs at visits, vital signs, and injection site reactions. So they got a lot of information there. Kind of routine labs and EKGs is not something that I'm kind of routinely performing or I've seen kind of recommendation for. So they got lots of data points.
I order a lot of routine labs. No one ever goes.
Yeah, they do expire, don't they?
They sure do.
So the results kind of, very interestingly, the rapid induction group really kind of outperformed here in almost every domain. So when you look at the primary outcome, retention and injection 2, there was higher in the rapid induction versus standard induction. It was about a 12% difference in terms of retention. That was 66.4% versus 54.5%. When you really looked at that fentanyl positive subgroup, that's really where the rapid induction kind of really made a big statistically significant difference. So there's almost a 15% improvement in terms of retention with the rapid induction versus the standard induction in the fentanyl positive subgroup. So our most difficult patients in terms of initiation. And that was 62.8 versus 47.9%. Retention and injection 3 favored the rapid induction with almost 59% versus 51%. And there was really no significant differences in fentanyl negative drug tested patients at initiation in terms of kind of the subgroup or reanalysis there. So it really, your results were most substantial in this fentanyl positive group. Adverse events were not surprisingly similar between the two groups. They have a really nice kind of graph that you can look at with the article, which really showed kind of CAL scores by kind of different dosing as you went through. And, you're really looking for the risk of precipitated withdrawal with kind of this rapid induction group or kind of an uncomfortable initiation. And not surprisingly, the fentanyl group definitely had a higher CAL score, more signs of autonomic instability and withdrawal. But it wasn't statistically significant whether you did rapid induction or standard induction. So kind of revisiting this case, this patient it was actually kind of sad. They just come back every week for 4 weeks and like, it just felt stuck. And, I think at this point I've become very cognizant of the fact that many patients, they don't want to keep going to inpatient. I feel like inpatient is not something that is foreign to them. Most of the patients that I treated different time courses have done this at some point. The idea of going back is something I think they try to avoid almost at all costs in many regards. So I told this person, if you're still not interested in any of the options I've discussed, I still would offer them if you're interested for them. But we could consider this off-label rapid induction protocol to get you to treatment and accelerate getting you on the medication, since I think we're having the biggest barrier in just kind of pushing through this. This would require you to abstain for as long as possible before that visit. But next week, we could do a 4 milligram dose that you currently have and then follow it up by the loading dose to get you more comfortable rapidly. And if possible, even do the second loading dose a week later to stabilize you. And I will tell you, this is one of the few times where I've like read an article and I'm like, yeah, I can do that. And I did. And it worked.
Yay. That's awesome. Yeah, I wish I had known about this from my patient a few years ago who just really struggled to get started on the buprenorphine. All right. You ready for case number 3? So this is a woman, 30 years old. She has been using fentanyl and heroin since age 19, and she comes in to discuss options for care. She has had multiple episodes of treatment for her opioid use disorder, including short and long-term inpatient treatment, buprenorphine treatment, methadone. She was on methadone a year ago with some success, but did not have transportation for her near daily visits at the opioid treatment program. So she tapered off the methadone and went on to buprenorphine. But she's kind of allergic to it. It makes her itchy, her skin crawls. I started her on buprenorphine alone instead of buprenorphine naloxone, but it didn't really help. And then she's using fentanyl again and having headaches and nausea and fatigue and swollen mouth. And I just keep adjusting and changing the dose and the schedule and the manufacturer. But I can't find a dose that both eliminates her fentanyl use and doesn't have pretty significant side effects. So she doesn't really know what the next step is, and she still has no transportation to the methadone clinic. So what I had said to this person was like, I don't know. I can't say methadone is better than buprenorphine. The data is not really there if I'm trying to recommend one over the other. Fentanyl, is really hard to manage, and a lot of the methadone data is a little old before the era of fentanyl. Going to the methadone clinic is a real pain in the butt. So let's just keep working with the buprenorphine. That's what I work with. And let's just try working with the buprenorphine and see if we can find something that works for you. And then I read this article, which came out at the end of 2024, buprenorphine naloxone compared to methadone for the treatment of opioid use disorder in JAMA 2024. So really comparing buprenorphine and methadone in this modern era. So John, if you have a patient who's trying to choose between methadone and buprenorphine, what do you say is better?
I mean, I don't think that that's like a one-line answer, right? I think it's kind of let's talk about what you're looking for here. I think that both have a very compelling use and can be used in the right situation. So I don't know. I frequently refer people between the two all the time. I take people back from the methadone program and I refer people over, and it's kind of whatever they need at the moment.
Well, and in the U.S., there's not a lot of good comparative effectiveness research between them because the settings are so different. Methadone has to be given in this highly structured daily visits for many weeks, methadone clinics, whereas buprenorphine can be prescribed by anyone with a DEA license and is usually given in the office. So it's hard to compare the two. But this study was done in Canada where buprenorphine and methadone have similar regulations. So buprenorphine is more regulated and methadone is less regulated. So the treatment experience is very similar for the two and allows for some good comparative effectiveness research. So the clinical question is, what is the risk of treatment discontinuation and mortality among individuals receiving buprenorphine naloxone versus methadone for the treatment of opioid use disorder? So our big outcome, mortality, which is better, buprenorphine or methadone? So this is a retrospective cohort study done over 24 months. 30,891 Canadians with opioid use disorder were in this study. They were mostly at large addiction clinics, and you had to not be on medication for opioid use disorder, and then you got to choose your discretion, methadone or buprenorphine. So it was a retrospective study, not a randomized controlled trial, which would be really what we need. 39% chose buprenorphine, a 61% chose methadone. And you had to be starting medication new. They did have a small subset of people who were starting medication and had been on it before, but they weren't on it at the beginning of the study. And the outcomes were treatment discontinuation or all-cause mortality. So bottom line, the risk of treatment discontinuation, meaning stopping treatment, was higher among recipients of buprenorphine naloxone compared with methadone. 88.8% for buprenorphine naloxone, 81.5% for methadone. So pretty high treatment discontinuation, but higher with buprenorphine within 24 months. The risk of mortality was very low in both groups, 0.8% versus 0.13%. The mortality data, though, was a bit ambiguous because the overall low mortality in this study. There was minimal change in the various sensitivity analyses they did. They also did a protocol analysis looking at people who actually received the medications at optimal doses. Again, same difference in treatment discontinuation. They looked at all these subgroups: youth, people with pain, people with mental health disorders, people with fentanyl use before and after the introduction of fentanyl, different discontinuation rules at different clinics. Basically, no matter what they looked at, the methadone kept people in treatment longer. So case 3, again, this patient who really does better on methadone, it really makes me say, like, yeah, here's a pretty strong methadone mortality benefit. It's probably going to work better for you. Let's try to figure out this transportation thing. What can we do to get you to the methadone clinic? And it also made me comfortable. I can't prescribe methadone for opioid use disorder, but if it is ever deregulated or liberated from federal regulations, I will look forward to being able to prescribe it as well. So how about you, John? Do you prescribe methadone?
Well, no.
You're on the air.
I treat no one with opioid use disorder or methadone. I do have a single patient on like 5 milligrams that I took from a pain clinic, but well, that's for something different.
Yeah, I have a pain. Yes, I have a pain management patient who has no history of opioid use disorder who is I'm treating with methadone.
Yeah,
a single patient.
It's like
as
these
well.
salvage from the clinic, and she's the nicest lady ever. And so she doesn't have to go see them every 2 weeks. I see her every 3 months. And she's fantastic. Yep.
Perfect.
Yeah.
Win-win.
But I think it'll be interesting when it is kind of we have some more options for this. I do think locally in our community, there's more that have opened up. There's another one that's recently opened, and I have more patients kind of that I think felt that now that there's more options for them, they actually did go that route. I'd be interested to see if they do better or what that actually looks like. But I think more treatment options is always a great thing, right?
Yeah, agreed. All right, ready for our last case of this episode?
This was like a controversial one that I loved, had a lot of good discussion. So it also kind of reflects like if you got in like time machine, like Marty McFly and hung out with me in my clinic like 10 years ago or 7 or 8 years ago, what you would have seen. So don't judge me today. So as a 24-year-old male who presents for treatment of opioid use disorder, his past medical history is significant for tobacco use disorder and bipolar disorder. They were referred to your clinic by the Addiction Services Warm Line after responding to an emergency department visit for an overdose. He reports using 10 to 20 pressed Percocet daily over the past 3 months and resumed use following his ED evaluation 3 days ago. The patient is interested only in outpatient medication management and does not wish to engage in adjunct behavioral health services such as counseling or an intensive outpatient program, citing time limits and availability. What I used to think, and I am kind of shameful of this before, if you saw me as a new patient 8 years ago, IOP was pretty standard for every patient that came to me. And that was often, quote, a requirement to be part of the program. I used to feel that, I'm glad that they're here to pursue outpatient treatment, but if they want to maximize their success, they really need to kind of take their recovery seriously and engage in everything that's possible, including behavioral health. I've kind of laxed over the years, but this article was very useful at kind of making me feel better about that. And it's called Behavioral Therapy as an Adjunct to Buprenorphine Treatment for Opioid Use Disorder, a secondary analysis of 4 randomized clinical trials, and it's from JAMA Network Open. Sonya, how do you feel about that topic?
So I've had a lot of shifts over the years. I definitely started working, my buprenorphine career working with a community organization that required, a behavioral component. You had to go to group. you had to engage with recovery support. And if you didn't, you were dismissed from medication management as well as the program as a whole. It was also abstinence only. So if you used other drugs, you also could be dismissed from the program. And that seemed right to me at the time when I first started. But, over time, I had read some data that showed that actually it didn't make a difference. And also I kind of stopped working with that community organization and shifted over to working with our own recovery support at St. Max's. So now I no longer require anything, at all. I mean, I require that you engage with me and come in to see me if you want medication. And what I found, and, I think this is actually something you've said that you've convinced me of, that like, if you want to just get off opioids, medication is pretty much what you need. If that's your end goal, mortality, overdose, and getting off opioids. But if you want your life to come together in a lot of ways, and you're struggling with that, you need behavioral component.
Yeah, so the clinical question here, does adding behavioral therapy to buprenorphine and medical management improve treatment retention, opioid use, or functional outcomes in individuals with opioid use disorder? And do specific subgroups benefit more? Which I think is actually, it's a secondary question. I actually find that the most interesting question here. So the methods here was a design of a secondary analysis of 4 RCTs from 2000 to 2011, included 869 adults across 13 U.S. sites. Participants all met DSM-4 opioid dependence criteria, so kind of blast from the past there with DSM-4. They received buprenorphine with medical management with or without behavioral therapy, including those with heroin use, pain, depression, PTSD, and prior treatment. So it's like looking if those subgroups perform better, okay, with or without behavioral therapy. And the primary outcome was illicit opioid use, so opioid-free weeks. It also looked at buprenorphine treatment retention, weeks on treatment over 12 weeks, functioning across medical, psychiatric, social, legal, and employment domains. And they looked at this kind of addiction severity index to quantify that. And I think it was very interesting. And, the results for these 4 kind of melded studies was that there really was no difference. There's no difference in opioid use, buprenorphine retention, or functional outcomes with added behavioral health. So that was kind of a standard approach. And I was actually incredibly surprised that there wasn't a statistically significant subgroup benefit in the PTSD, depression, pain, or heroin/cocaine group, particularly the PTSD, depression, and pain group. Because I feel like those groups, we have data that behavioral health components kind of improve all of those outcomes. So the fact that it didn't make a difference here was very interesting to me. Same case now coming back. This is what I typically kind of approach people with today. So first visit, you see me. I don't lay out all these rules. You have to do this. You have to do that. I mean, you have to come see me and you have to not sell the medication. I think those are kind of my 2 like hard things. But otherwise, and you got to like store it someplace a kid doesn't get into. But besides that, there really isn't a bunch of hard rules. I've kind of mellowed with age and gray hair. So often I'll tell people at the first visit, I'm glad you came in today and reached out for help. While many patients do benefit from behavioral health component as part of recovery, not everyone chooses this or needs this to succeed. Let's start with buprenorphine initiation today. We'll follow up in the office in a week. And at our follow-up visits, we're going to assess each time what you need to succeed. And that may or may not involve a behavioral health component. And, it's interesting. I'm not ready to throw that. I mean, I think that when we first did this article, some people were like, thought we were like trolling all of our psychology colleagues. I think they have a very important role in this. I think it's just this blanket. Everyone needs this one thing, In medicine, the answer is never always and never, never.
Well, and the other thing is that buprenorphine has a unique place in the treatment of opioid use disorder in that it's easy to prescribe. It's pretty safe. Everyone can prescribe it and it works really, really well. It just works great. And so there is less need for these other harder things, the behavioral things, and it's sort of like everything. If we could take a pill and fix all of our medical problems, like that'd be awesome. Who wants to do the hard therapy work if a pill would fix your problems? Yeah.
And I know it's a validated, I think that this is something that kind of comes up in the literature is like, what is recovery? What's a successful outcome, right? We talk about this like repeatedly. It's probably one of our most common tangent rants. And so, I think here they're looking at this addiction severity index as really kind of a marker of kind of like functionality outcomes beyond just kind of the opioid free weeks and kind of the UDS or the plus or minus binary categories. And I think that the truth of the matter is, I think if we were to have more information and you were to have a more encompassing definition of recovery, you might find some statistically significant differences in certain domains when you look at a more global sense of recovery. So I think it's an interesting study. Definitely gives me food for thought. I mean, it's kind of validated my kind of laxity with this as time has gone on, but I still think it has an important place.
Yeah, agreed.
All right. Well, that was our first 4 episodes. So thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from MyCares, produced by Dr. Patrick Beeman at Arslanda Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation.